Good evening, everyone. So to moderate this session, we have Dr. Sumit Gupta, who is a head and neck surgeon from DMC Cancer Center, Ludhiana. So before I hand over the screen to Dr. Sumit, we want to introduce or we want to invite you for the program's upcoming webinars conducted by the Academy of Head and Neck Oncology of Karnataka. So Bhargav, can you please share the flyer of the laser conference?
Yes, sir. One second.
So we from the Academy of Head and Neck Oncology of Karnataka are launching a series of continued online medical education series on minimally invasive head and neck surgery. The first module of this series is on transoral laser microsurgery starting tomorrow. So it is divided into two sessions, that is tomorrow on the 28th and the next will be on the 5th of July on a Sunday between 12 to 4 o'clock. So we have got eminent international faculties. So we got, so this meeting is co-hosted by Chris O'Brien Lifeforce Hospital, University of Sydney, where Professor Carsten Palm is helping us with this meeting. In addition to Carsten Palm, we have Farouk Rifat and Professor Daniel from Sydney. And from Italy, we have the pioneer laser surgeon, Professor Giorgio Peretti, Professor Cesar Piazza, and Dr. Francesco. We also have eminent faculties from across India, and this is going to be a very educative event on transoral laser microsurgery. Next up, after we finish our neck module that is today, so next month onwards, we will be having sessions on cancers of the oral cavity, which my colleague, Dr. Shalini, will be coordinating. And we have got eminent faculties across India and a prominent international faculty, Dr. Ashok Shah, participating in this meeting as well. So the first oral cavity webinar is on oral pre-malignant disorders, which will be delivered by Professor Devendra Chaukar. So with this little introduction, I hand over the screen to Dr. Sumit to introduce Madam and take the session forward. Sumit, over to you.
Yeah, thanks, Akshay. Good afternoon, everyone, and good afternoon, ma'am. Today's topic is dealing with the complications in neck surgery. It is a very interesting topic, how to prevent the complications and how to handle if complications occur during the surgery or after the surgery. Dr. Gauri, everybody knows, is a professor at Tata Memorial Hospital, Mumbai. She is a very good surgeon. She will enlighten us about this topic, and question answers of this session will at the end of her talk. So, ma'am, please start your talk now.
Good afternoon, everybody, and thank you to Akshay and his team and Sumit for that introduction. I'll start my share screen. Okay, can you visualize the screen?
Ma'am.
Are you all able to see it?
No, ma'am.
No.
You are screen sharing, it's come.
Not coming, ma'am.
Can you stop and again restart the screen share?
Pause the share and resume the share.
Yeah,
now
it's coming.
Now we can see.
Yeah, it's working.
Okay, perfect. Great. So I'm going to be talking today on complications in neck surgery. And when they say neck surgery, I assumed that it is neck dissection because a lot of neck surgery has complications. You can have a laryngectomies in the neck, thyroid is in the neck, but I've restricted myself only to neck dissections and the prevention and the treatment of these complications. Now, they are common. Neck dissection complications are common, and this is because of the really intricate anatomy of the neck. So many vascular structures, nervous structures, muscles, important aerodigestive tract organs are all lie in a very small confined place. And injury to any of these would lead to complications of neck dissections. Now, the rates of each complication are actually difficult to identify, and this is because of the heterogeneity of the surgery and the surgeon skill and different varied types of types of people who do this kind of neck dissection. It also depends on whether you are prospectively auditing your complications or no. Otherwise, rates of complications are often underreported. It can affect any surgeon regardless of the skill, and I think that's important to know. It's the most humbling when you get a complication even after doing years and years of neck dissections and surgery. So really can affect any surgeon regardless of skill. It's important to have surgical awareness, early recognition, and prompt management of these complications. Now, the implications are many, and you all are aware of it. Many of you all are surgeons. There's a lot of morbidity, increased surgical stay, increased cost, delay of adjuvant therapy, medical litigation, and overall, sorry, this slide is not moving. A lot of stress and actually decreased life expectancy of the surgeon itself if you have complications. So really, it makes sense to prevent these complications. Now, these are general risk factors that are there in all surgeries. You have patient factors, you have like age, anatomical variations, prior radiation therapy, previous surgery, and you have disease factors like if they're undergoing an extensive resection, aerodigestive tract injury, prolonged anesthesia, and plastic reconstruction. Now, undoubtedly, prevention is better than cure. And as Sumit also said, I think it's important for us to highlight a little bit more on prevention. And there's something that I want to first start off with before we go on to each of those complications, and that is the use of surgical checklists. Now, this was an article that was published and it made it to a New England Journal of Medicine on a surgical safety checklist to reduce morbidity and mortality in a global population. Now, what was done was in this study, 8 centers were included, and this was also done at St. Stephen's Hospital, New Delhi. These were global, these were general surgery cases. It's not absolutely related to head and neck surgery. They documented their complication rates and identified deficiencies. There are 2-step implementation of the 19-item WHO safe surgery list was done. And this checklist was done at 3 time points: before induction of surgery, before incision, and before patient leaves the operating room. And see what they found. These were the number of patients who were, these were the records seen of the patients who did not have the checklist done, and this is after the checklist done. There was a significant reduction in all types of morbidity: surgical site infection, unplanned return to operating room, pneumonia, death, any complication, just by the simple use of the surgical safety checklist. Now, since 2009, we have modified this surgical safety checklist. It's out. We have published our data on this also. And I urge all of you all, the first step to decreasing complications is to first put in a surgical safety checklist in all your institutes. Now, let's come to neck dissection and the complications. I've classified them into intraoperative complications and postoperative complications. Intraoperative complications are numerous. You have multiple nerve injuries. I've listed a few. There are many more nerves. You can have vascular injuries to the internal jugular vein, the carotid artery, injury to the thoracic duct. Postoperative injuries, wound-related problems like wound infection, flap necrosis, seromas, salivary fistulas, carotid blowout, subcutaneous emphysema, pneumothorax, lymphedema. There are so much. It's just a small neck dissection, and all of this or either of this can happen in practically every neck dissection. So we are not going to be able to cover all these injuries. So I'm going to look at some of the common ones, and the topics that we are going to be discussing today is both preventing and managing certain important complications of neck dissection. So I'm going to talk about in intraoperative complications. I'm going to look at 3 nerve injuries. That's marginal, spinal, accessory, and phrenic nerve injuries. Looking at vascular injuries, the internal jugular vein and carotid artery injuries. We're going to look at postoperative injuries, in the postoperative complications in the form of wound infections, chyle leaks, and salivary fistula. If there is anything beyond this that anybody would like to discuss, I'm free to take any questions for any of the other complications of neck dissection. So let's start with the nerve injuries. Let's start with the first one, that's the marginal mandible. It's actually, frankly, the most common nerve injured. The incidence is 18 to 23%, but it's often underreported. And many of us don't even ask our patients to smile after surgery just because we're scared that, maybe their angle of mouth is going to be twisted and that will become a marginal mandibular nerve injury. So often very underreported. If you look at the predisposing factors, one of the first things is raising a thick flap. That's if you have fat on your flap. The second is non-identification of the marginal mandibular nerve before ligating the facial artery. Third is an excessive retraction on the ligated stump. Inadequate tracing of this nerve all the way posteriorly. If you just identify the marginal mandibular on the facial artery and you don't trace posteriorly, when you're going ahead and doing the 1B clearance at the entry of this nerve into the entirely up to its origin from the parotid gland. Use of monopolar dithermy near the nerve often causes neuropraxia. And if the patient has bulky level 1B or perifacial nodes, in spite of really meticulous surgery, marginal mandibular nerve may be. So these are the potential sites of injury. If you see, this is the nerve and it crosses the facial artery. So you can injure this nerve because all of this has to be removed when you're doing a level 1B clearance. And when you're trying to tie the facial artery and vein, you may injure the marginal mandibular. This gives rise to asymmetric motion of the angle of mouth, accumulation of food while chewing and drooling. And though many of our patients don't complain about it, it is pretty distressing to these patients. So it should be prevented and avoided. Now, no real treatment. Most of the times you don't cut, it's only a neuropraxia and they do recover. Patients can be given physiotherapy and they can be treated. What is really important are the preventive measures that you have to take to avoid marginal mandibular nerve injury. And here are some of my tips. One is you raise a pink upper flap. That is only platysma, no fat on the flap. Avoid keeping the ties on the facial artery long. This is something that we used to do, and then you pull the facial artery upwards along the tie, and that causes traction, in fact, on the marginal mandibular nerve. Avoid using monopolar dithermy. Dissect the entire course of the nerve up to its entry into the parotid gland. Now, some people have thought of using intraoperative neuromonitoring for marginal mandibular nerve, and this is something that I found on intraoperative monitoring of margins. There's very few reports. It's something really interesting. And here is a paper where they compared two groups: 36 patients with 45 neck dissections in which they used the intraoperative nerve monitoring versus 35 they didn't, and they looked at incidence of marginal mandibular nerve paralysis. Now, the overall palsy rate was 11.96. phenomenally low actually. In the IONM group, it was 4.08 versus 20.93 in the non-IONM group, which was statistically significant. So this is an upcoming modality, really hasn't been tried, and this is too small a group and a very poorly conducted study to actually think of using this in practice. And most importantly, there is a huge added expenditure of nearly 365 euros per patient for doing this. So what probably is going to work is you have to take a lot of care. And here is a small video clipping of one of the neck dissections that I have done. And I hope this video works to see how we dissect the entire marginal mandibular nerve. So the first thing, as I said, is to raise this pink flap. This flap has to be absolutely, don't raise too much beyond the lower border of the mandible. Your flap should look red like this. If you leave fat on it, many times you may take the marginal mandibular nerve. Once you find the marginal mandibular nerve, dissect very, very carefully. Don't hold the marginal mandibular nerve. Dissect it both anteriorly and posteriorly. Use a bipolar Khatri. See the distance that we are dissecting the marginal mandibular nerve, not just where it is over the facial artery. Dissect it all the way posteriorly. When you're identifying and clipping the facial artery, see that you have an adequate distance from the marginal mandibular nerve. So this is the nerve, you're clipping this much lower, keeping a complete distance from the marginal mandibular nerve. So these are certain small tips that you can do, and once you cut this and tie it, cut off the ties. Don't hold it as a traction for this. Let's go to the next nerve, the spinal accessory nerve. Now, the incidence of this is reported. This is more research. Spinal accessory nerve injury and shoulder dysfunction is far more research than marginal mandibular nerve. Now, predisposing factors are undoubtedly, there are two areas where this nerve has a higher chance of injury, and that's at level 2B and level 5. So if you have large nodes at level 2, there is a chance of injury to the spinal accessory nerve. And when I mean injury, it does not mean a complete transaction. Excuse me. I mean injury as in functional injury. It can be ischemic, it can be a traction injury. It doesn't have to be, it rarely is a complete transaction. If you raise a thick skin flap again at level 5 for level 5 clearance, this is again a nerve that's very close to the skin flap, and you may damage it at this portion. The second thing is you may not damage it anywhere, but if you don't leave that little sheath with the blood vessels on it, it may cause devascularization of this nerve and it may not function. The final thing is that you have to be aware of the spinal accessory nerve having variations in course, and if it's not in its usual position, there is a higher chance of damaging it. So these are the variations of the spinal accessory nerve. In most cases, 96% of the time, this is the digastric muscle, this is the internal jugular vein, it crosses above it. In a few patients, 3%, it goes behind the internal jugular vein, and in 1%, it goes through the internal jugular vein. This is extremely rare. I've seen it in only one case. But if you do enough number of neck dissections, you will definitely find the spinal accessory nerve going below the internal jugular vein. And that sometimes disturbs you, and you tend to injure the spinal accessory nerve if you aren't aware of this variation. Now, if you look at the potential sites of injury of the spinal accessory nerve, dissection of level 2A and 2B, this nerve retraction that we do for this 2B clearance often causes traction. It doesn't translate into a very severe shoulder dysfunction, but patients may complain of a little bit of inability to move the shoulder. The second part where there is potential site of injury is when you're raising this sternocleidomastoid muscle in a selective neck dissection, and if you go posterior to the posterior border of the sternocleidomastoid muscle, you may injure it. And when you're raising the skin flap for a level 5 clearance and to do a level 5 clearance. If you have large nodes, this is how the spinal accessory looks at the end of it when you've cleared all the nodes. Now, it's obvious that when you do these kind of dissections, there will be spinal accessory nerve injury in some form. This leads to what we call the shoulder syndrome, and patients may have a little bit of it or a large amount of it. This kind of deformities are no longer seen because we have moved from doing, these were seen in the days of modified radical neck dissections and radical neck dissections. They're not really commonly seen now when we are doing more and more of selective neck dissections. So here are the tips to identify and preserve the spinal accessory nerve. At level 2, identify the nerve in its entire course and as it enters the sternocleidomastoid muscle, dissect in its entire course, complete as much dissection in and around that area without traction, use bipolar forceps, and avoid level 2B dissections when not indicated. And we can discuss when level 2B dissections are indicated or not indicated. At level 5, raise a thin skin flap, identify the nerve exiting at the Erb's point, and it's interesting to see. It's important to note its distance from the greater auricular nerve, which will give you your first guide to identify it. Trace the nerve again with the use of bipolar forceps. Avoid lifting this nerve from the bed unless you have large number of lymph nodes in the 5A region. And once again, just like avoiding level 2B dissections, avoid level 5 dissections when not indicated. This will definitely decrease your injuries to the spinal accessory nerve. Now, God forbid you do have a treatment of intraoperative injury. You have an intraoperative dissection of your nerve. It's absolutely important that you do a primary neurography. And this is a case where the nerve has been injured and we have done a primary neurography. In most instances, you don't have a huge nerve loss, because these are just transactions that have happened. But if you have a large lymph node and if you have the proximal and the distal ends and you have cut a section of the nerve in between, you can even put in a cable graft. There have been good results shown for shoulder function after and EMG studies have also been done after doing neurography. So if you cut the spinal accessory nerve, identify it, and please make all attempts to do a primary neurography or a cable grafting on table itself. Now here is again another small video on the dissection and identification and the care that you have to take for the spinal accessory nerve. We have exposed the digastric over here. This is the digastric. A good exposure of the digastric is important. You remove all the lymph nodes that are above the level of the spinal accessory nerve. Do not go too deep below the sternocleidomastoid anterior border. Once you identify the nerve, which corresponds to the upper 1/3 and the lower 2/3, dissect out the anterior part of the nerve using a bipolar forceps all the way superiorly. Otherwise, you won't get a good clearance. You have to be very gentle. If you open your mosquito forceps too much, you'll have bleeding. See, the important thing is to keep this field white and clean. Then you'll be able to see the nerve clearly. If there's a lot of bleeding, there's a lot of vessels. You can see all these vessels here. And you have to be careful. Don't just start using your cautery immediately. Get this little bit, release this nerve a little bit so that the entire 2A tissue will come out and you won't need traction of this nerve. We'll come to the third nerve, and that's the phrenic nerve. Now, this is a nerve which actually not many people talk about, and there isn't too much of documentation because the consequences of this are not often seen because patients can do very well with just a diaphragmatic palsy. Even if the patient does have a diaphragmatic palsy, they may have no symptoms at all. Now, the predisposing factors for and where you can damage this is when you have mid or lower jugular nodal dissection and large level 4 nodes. But more often than not, you don't need to have big nodes. We have seen a large number of phrenic nerve injuries that happen in spite of there being no nodes at level 3 and level 4. And that's because you have to be very careful in these points. One is that when you're doing a level 4 dissection, you should not breach the prevertebral fascia. If you damage the C2, C3 nerve root injury, while repairing an intraoperative chyle leak, you may damage the phrenic nerve. And if there is blind clip application to control level 4 bleeding, it may be a potential site for injury. So you don't need to have large lymph nodes to damage the phrenic nerve. You may damage the phrenic nerve and you won't even know about it if you do any of these things. These are the potential sites of injury. So this is how the phrenic nerve looks. This is the phrenic nerve that's on the anterior scalene muscle. This is your transverse cervical artery. This is your transverse cervical artery. And you can see that it's in close contact in this area where we dissect. And if you have bleeding from here, it's very easy to catch this phrenic nerve instead of catching one of these blood vessels. So important in this area to know that there is a phrenic nerve which has a pretty bad, devastating complications actually with diaphragmatic palsy. Now, many patients are asymptomatic and do not present with anything, but some may present in the postoperative period with dyspnea and exertion, inability to ambulate, which are subtle signs, and pulmonary complications. And you don't realize why a patient in whom you just did a wide excision tongue with a neck dissection is having so much of difficulty in breathing. And then when you do the chest X-ray, you can see that you have a hemidiaphragm. There's an elevation of the diaphragm, which is a classic indication of phrenic nerve injury, and you don't lose your angles over here, your costophrenic angles, which differentiates it from pleural effusion. And sometimes if you're unsure what this is just gas or what this is, the thing that clinches the diagnosis is an ultrasound of the chest, where which is a dynamic procedure, and you can see that there are reduced movements as compared to the opposite hemidiaphragm. So these were the potential sites of injury, and really the treatment for phrenic nerve injury is to prevent it. So for at level 4 dissection, to prevent breach of prevertebral fascia, the first thing that you have to have is good exposure. If you're doing level 4 dissection in a very, very small, narrow place, you won't be able to even identify when you have gone below the prevertebral fascia. Avoid cutting nerve roots as a policy in most, since we're doing selective neck dissections, avoid cutting nerve roots. While repairing an intraoperative chyle leak, take a superficial stitch. If you take a deep stitch that goes through the prevertebral fascia, you may take the phrenic nerve in your stitch. And stay medial, because the phrenic nerves, in most cases, are a little more lateral as compared to the carotid sheath and the chyle duct. Avoid blind clip application to control level 4 bleeding. And since the advent of clips, this used to not happen so commonly when we used to tie them, because we had to then pick it up and tie. But if you do blind clip applications, then you may sometimes just put a clip on the phrenic nerve. So identify the vessel and then clip it when you're looking at hemostasis in this area. Let's come to vascular injuries, okay? Internal jugular vein injury, predisposing factors. Most of us who have done nerve dissections would have hit the internal jugular vein sometime or the other. It generally has seen in when you have mid-lower jugular nodal dissections, large nodes, redo neck dissections, post-radiation surgery, inadequate exposure, and very often the thing that really gets hit is the lateral branch, and it's something that you don't expect to come at the level 3, level 4 level. And while you are just moving your Khatri and trying to remove all the that causes a rent in the internal jugular vein. Now, the first thing, of course, is in any vascular injury is to keep calm and to apply pressure with the finger on the rent. And this is for any vascular injury. Avoid trying to immediately start clamping things using mosquitoes and other clamps, and that just makes things, it's absolutely a low pressure system. So if you put a finger on it, or you ask your resident to put a finger on it, arrange for your instruments, arrange for your suction to work well, get your gauze pieces, and then you can go ahead planning what you need to do. Now, these are some of the guidelines that I've put through on how to manage an internal jugular vein injury. If you have a small point rent, expose the area adequately, suction the bleeding, hold the rent gently with a vascular forceps, and do a venography with either a 5-0 or a 6-0 Proli. If you have a larger rent, and this venography sometimes reduces the lumen size, you have to put pressure on, but it's quite a big, for all cases, you must try to first do a venography. If you feel that it becomes a small lumen, low flow, and that causes thrombosis, you may even have to do a patch graft. If you don't have access to a vascular surgeon, then you may just leave it like that, which is almost as good as a ligation. Sometimes what happens is if you have a large level 2 lymph node and you have absolutely no stump to catch superiorly, and you have to cut the IJV gets cut superiorly with no stump to catch or ligate, it's a torrential bleeding. But really, it works very well with a little bit of pressure till you organize everything. All you need is to give pressure. You assess it, and you will have to take a figure of 8 stitch with continuous suction. While it is bleeding, using a good suction, you can take a figure of 8 or a vascular stitch. And sometimes this only gets controlled, even the stitch does not work with use of gel foam and Surgicel. The other thing that you have to do is, if you put a drain after the surgery, you have to see that this does not go in and cause a negative pressure suction, because this is something that is just closed down and it will open up. If you have a rent inferiorly, it's more prone for air embolism. So you have to apply a clamp a little more quickly, flood the field with saline, reverse Trendelenburg position to prevent air embolism, and identify and do a venography and transfix. It is an easier procedure than when superiorly it gets caught. Let's come to carotid artery injury. Luckily for all of us, it's a rare complication. It forms less than 1% among the complications of neck dissections. Predisposing factors generally are, I think this is the commonest cause. It's not been mentioned anywhere in any thing, but really one of the things that causes very few carotid artery injuries, but it's because of the carotid bulb protrusion in level 2, and you are not able to distinguish it from a node and you hit it. Multiple large level 2 and 3 nodes with encasement of the carotid are common, and this happens more so in surgeries like thyroid cancer surgery, where you're actually attempting, or when you're trying to do parapharyngeal tumors, where you're actually attempting this kind of surgery. In most other cases like squamous carcinoma, you won't even attempt a surgery. So this is more common, and you have to be aware of it when you're doing surgery for things like thyroid cancer surgery, where even with an encasement of the carotid, you may have injury. Excessive cautery usage sometimes causes a pseudoaneurysm and a weak serosa, and this may cause a carotid artery injury. As we are aware, these are devastating neurological complications, a lot of blood loss, and it's a difficult situation to manage. And frankly, according to me, this should be handled by a vascular surgeon. So it should be at the earliest that you call for a vascular surgeon. But in the meantime, what you need to do after an injury to the carotid: avoid use of clamps. Once again, unless it's a very large rent and you're worried that this patient is going to exsanguinate, Please do not put clamps on the carotid artery. Finger pressure is adequate even for carotid artery. And to some extent, not that we're sure of this, but just a technical tip, for some extent it does let the carotid circulation continue, especially in patients who may have an inadequate opposite side carotid circulation. So finger pressure is adequate. You have to oxygenate your patient well to avoid brain injury. You give a head low position again for brain injury. Arrange for blood and blood products. And as I said again, this is probably something that needs to be dealt with by a vascular surgeon. Call a vascular surgeon to help you rent for a carotid artery injury. Let's come to the second section of this talk, and those are on post-operative complications. The commonest complication that we have
sound is not clear.
Neck dissection is actually hematoma, and it's like a continuous. Sorry, can you hear me now?
Yeah.
Hello.
Yeah,
Should I continue, or do I go back?
No, you can continue.
Okay. So this is seen as high colored blood along the drain tubing. Sometimes the drain may have got clotted. So you have blood or clots around the drain in the incision, and you have a classical sign of floating flaps. That is, the flap is not stuck to the neck and it's floating, and you have an expanding neck hematoma. Sometimes you have compression symptoms and tachycardia. Now, the question here really is not, it's an easy thing to diagnose. And the question here is, when do you go for immediate surgery versus conservation of a neck hematoma? And in most cases, I must say that we do go in for immediate surgery, but there are few cases in which you can conserve your hematoma. If you have a very small clot, most importantly, your neck flaps are stuck. And more often, you should be sure that this is a venous bleed and not an arterial bleed. If there is no rapid increase in size, and on investigations, there is no fall in hemoglobin or associated coagulopathy, then in these patients, you cannot let the patient be. This patient has to be very closely monitored. So it's something like an active surveillance. It's not just a conservation of hematoma. It's a dangerous situation. So if you do not have access to good monitoring, you have a lot of residents, ICU, it's always better to go ahead and re-explore a hematoma and to manage the bleeding intraoperative. Let's come to the second more common, little slightly boring complication, that's wound infection, though I think it really increases the morbidity. After a neck dissection, if it's a clean neck dissection, not many patients have wound infections. It's probably always associated when it's a clean contaminated surgery. So blood loss, clean contaminated surgery, presence of a tracheostomy, advanced T-stage, flap reconstruction, and long operative time are all predisposing factors for having more wound infection. The most common, of course, is a clean contaminated surgery. That is when you have communication with the aerodigestive tract. The other potential factors are if you have not given timely antibiotic prophylaxis, not just preoperatively, but every 4 hours that you are in the operating room, this antibiotic prophylaxis needs to be repeated. If intraoperative asepsis is not maintained and poor postoperative sterility, then these are all predisposing factors for wound infection. Now, clinical features, we've learned this long back: erythema, fever, it may move to septicemia, pus and drain slide collections. The general investigations which you would send depending on the severity would be a complete blood count, wound swab, blood culture, and in some patients, if you're trying to diagnose sepsis, or CRP and a procalcitonin. Now, how could you treat a wound infection? And this is some nice guidelines that we have depending upon the Clarion-Dendo grading system. If you have grade 1, which is a small infection which is not actually moved on to becoming pus, you can maintain strict asepsis erythemas, and you can observe these unless you have done a vascular repair. If you've done a vascular repair or something like that, then this has to be, even a grade 1 infection has to be taken very seriously. For grade 2 infections, which is localized pus collections, these can be drained either bedside or in your minor operation theater with regular washes. Keep wound open with a corrugated rubber drain. I am not very fond of using antibiotics for a grade 2 infection where there is no systemic sign and there is only a localized pus collection, but that can be changed and people can use empiric antibiotics. A grade 3A, which is a larger local collection, tissue necrosis, you need to have pus evacuation and minor debridement, keep the wound open, regular washes, and in this case, probably empirical antibiotics are to be taken. You change them to definitive antibiotics after culture sensitivity. Very large collection would require larger debridement. This may have to be done under general anesthesia. You have to look out for certain things like if you are, it's a clean contaminated surgery, there is an oral cavity fistula that has happened, which is causing this pus collection. Or sometimes even if you have left a foreign body like a gauze or something like that, which is causing such large pus collections, because it's rare that in a neck dissection you would otherwise get that. Grade 4A would be early sepsis. And of course, here you will have to treat maybe in the ICU, and antibiotics as per culture sensitivity may need higher antibiotics and supportive care. And late sepsis is very, very rare, life-threatening, and that you have to treat in an ICU. Let's come to chyle duct injury as chyle leak. Now, the incidence of chyle duct injury is 3 to 5%. I believe that's a very low figure, and I think there's much more chyle duct injury. It's commonly seen in the left neck, but it's not uncommon in the right neck, and you may have multiple lymphatic ducts. It's often seen in dissections for thyroid cancers, and the predisposing factors are large nodes at level 3 and level 4. And dissection medial to the internal jugular vein, and this is where you talk about thyroid cancers, where you're doing the central compartment. So this is the trachea and the esophagus, this is the carotid, and this is the internal jugular vein, and this is where your level 4 dissection. And we take a lot of care in this, but when you are in the central compartment, this thoracic duct may be a little high. And when you're doing central compartment clearance, even though you have clamped it here, you may injure it here, and then patient has a large amount of. So when you're doing central compartment clearance, especially when you're going to the root of the neck and clearing lymph nodes, you have to be very careful to not hit the thoracic duct. Now, there are two presentations for chyle duct injury. One may be an intraoperative injury where it presents like this and you can see chyle welling up, or the second is when you have a postoperative chyle leak. Now, for an intraoperative injury, you have both preventive measures and therapeutic measures. Preventive measures is basically very patient dissection of level 4. You have to level 3 and level 4. You have to have serial ligation and clipping of all tissue in that area, which may have a potential lymphatic. It's rarely the main chyle duct that leaks so much. It's most of the times the lymphatics, and it's a very erratic anatomy. It's not a fat, thick chyle duct that you see. And this is common both left and right side. So your level 4 dissection on your right side also has to be done carefully with serial ligation or clipping. Identification of small leaks has to be done with a combination of the Trendelenburg and the Valsalva maneuver after any patient who has undergone a level 3 or a level 4 neck dissection. Now, here is a small video again of level 4 dissection, and I'll show you how even unknown structures should be ligated. The first thing, as I said, that you have to get yourself into a good exposure. So delineate the omohyoid, get your exposure well, and then start your level 4 dissection. Now, after you remove the first top layer, for everything else, you need to dissect. Whatever you find that looks like a lymphatic should be clipped. It may not be a definite anatomical structure, and slowly with the bipolar forceps, you should avoid using saline squirts here because you won't find it. If you find a lymphatic that's bleeding, you can immediately catch it if you don't use saline. Use a bipolar forceps to complete this level 4 neck dissection. It needs to be done very carefully, slowly and meticulously to avoid having a chyle leak. Now, in spite of all of this, if we do end up with a chyle leak, what do? You try to clip or ligate the bleeding ends, and that is better seen if you do a Trendelenburg and Valsalva position. These ends which you have cut are actually very, very fragile to hold with forceps, and if you pull them, they'll just retract into the thorax and you'll never be able to find your cut end. In difficult chyle leaks, which even after this you are not able to find, one of the techniques is to open the carotid sheath. If you open the carotid sheath, you will go medial to the chyle duct and you will be able to take the entire chyle duct in your suture. Whatever repair you do, it has to be confirmed by no leak on provocation maneuvers. And really, you should have a absolutely dry field or a very, very minor leak before you come out. If you're going to rely on sclerosins, tissue glues, adhesives, muscle transfer in your first surgery, really the use is really doubtful. You have to be able to control your chyle, because otherwise in the post-operative period, most often than not, the patient will have a continued chyle. Now, suppose you see, how do you detect it in the post-operative period? If you have a high output drain, and sometimes it's just a huge output drain, you don't even see this milky fluid in it. And if you give a fat challenge to your patient, then you would find that this patient does have, and this happens when you are doing an iodine-free diet after thyroid surgery, and sometimes milk is avoided, and this patient doesn't really have this milky thing. So if you have a high output drain in a patient, and you are wondering what the cause is, one of the ways to do it is to give a fat challenge and to see if it becomes milky. Or these patients may present with supraclavicular fullness, and in rare cases, if it's a low chyle duct injury, then these patients may present with breathing difficulties and a chylothorax. Now, for low output leaks, and for most leaks are low output leaks, you would perform conservative measures in the form of weight and nutrition assessment, medium chain triglyceride diet, adequate hydration, adequate drainage of this, because it does get infected, and compression dressings. Now, there is a thought about using octreotide therapy, and I've really not found good evidence. This is one paper that was published from SMS Jaipur in Laryngoscope. The overall literature on octreotide therapy for chyle leaks is not on too many patients, especially neck chyle leaks. And these were 19 patients over a 10-year period. Octreotide was given as 100 microgram 8 hourly for 5 days in low output and for 7 days in high output fistulas. Low output fistulae, all 100% stopped within 5 days, and high output fistulae stopped within 7 days. More often than not, octreotide does not help too much. It's also prohibitively expensive. If you have more than 600 ml, you may conserve for a day or two if you have done a very major resection and you want to let your patient recover from it. But eventually, these patients generally require surgical re-exploration, which is quite a nightmare actually. You have to be able to identify and ligate, and often you have a pectoralis major flap, or you have reconstruction done in this area, and it's even more difficult. So it's very important to prevent this. And at this point, sometimes I do suggest that if it's difficult in a reoperated setting, and maybe after your ligation, you may need muscle transfer. In spite of this, if you have a recurrent chyle leak, then the only way forward is probably to doing a video-assisted thoracoscopic thoracic duct ligation done from the right thorax. And in very, very rare cases, we have done a few, and this is an extremely difficult procedure. You have to have a very, very trained and wonderful interventional radiologist who can do this, a percutaneous cannulation of the cisterna chyla and lymphoembolization. I'll come to the last complication, and that's the salivary fistula. Common complication, 9%. Again, I think underdiagnosed. Now, the predisposing factors is basically exposed cut salivary tissue in the neck. This is the tail parotid injury that happens during level 1B clearance, or if you have not identified and ligated the Stenson's duct. Now, clinical features is basically a clear watery discharge in the drain of the wound, and this appears similar to a seroma. Now, sometimes it's not, you can't differentiate it, but it does not reduce with course of time. And if you want, you can even do a serum amylase, but that's not very specific. You can see that many salivary fistulas do get infected and are associated with wound infection. Now, there was a concept that for every level 2 or level 1B dissection, you should cut the tail of the parotid that's below the angle of the mandible. That's no longer recommended. You can retract it unless there are lymph nodes in this area, because of which you need to cut the tail of the parotid. So routinely, it does not need to be cut. If for some reason you do cut parotid tissue in that area, it should be buried or underrun the exposed parotid gland during your neck dissection. If you develop a salivary fistula, you generally treat, most of these patients do well with conservative management. That's a combination of pressure dressing, oral or IV glycopyrrolate. Just watch out for urinary retention and don't give it in very elderly patients. And if nothing helps, then adjuvant radiation will definitely stop the salivary fistula. With that, I would like to conclude my talk and say that neck surgery has very high chances of injuries and complications, primarily because of the close proximity of all structures. We don't audit ourselves, and when you audit yourselves, you'll be surprised at the amount of complications, but it only helps you in identifying these complications and making changes in your surgical strategies, protocols, management, and that and complications significantly
Ma'am,
decrease if you audit your complications.
ma'am, voice is not clear last.
Luckily, most of these complications, except for vascular injuries, are non-life-threatening, but they do have serious morbidity. Please take good training. Hello?
Hello, yeah.
Can you
Hello.
hear me?
Yeah, ma'am, little bit disturbance was there, but it's okay
Please
now.
tell me when you can start hearing me.
Yeah, now we
Hello?
can hear you. Yeah, we can hear you, ma'am.
Hello?
Hello. Yeah,
Hello?
we can hear you, ma'am.
Can you hear me, Sumit?
Yeah, ma'am. Please. I can hear you, ma'am.
Hello?
Hello. I can hear you, ma'am.
Hello?
Hello.
Okay, you can hear me?
Yes, ma'am. I can hear you, ma'am.
Okay, thank you. So as I was saying, okay, Sumit, I'll continue. Yes. Okay, I will continue. So, as I was saying, yes, Sumit. Yes, Sumit, I got it. I'm continuing. Okay, so you need to take good.
Hello.
I think we lost her.
Yeah. Akshay.
Connect with madam. By
Yeah,
the time
please connect to madam.
Yeah.
There are a number of questions, and it was a very good and nice elaborated talk by the ma'am. Even the videos were good to avoid the complications and to prevent the complications and how to manage the complications during the neck dissection. Ma'am, are you there? Akshay?
So Sumit, you can. So there's some problem with the internet with madam's thing. She's back in 2 minutes. So in the meantime, so we can have a discussion on the certain questions which are on the chat
One
box.
question, Akshay, one question, interesting question is there. Oncological safety versus preservation of marginal mandibular nerve. Should one dissect it completely every time or not? Please go ahead.
So I think it's a very important point. So what is your take on when would you dissect a marginal mandibular nerve versus you
in my point of view, Akshay, oncological safety is the priority, but second is quality of life is also should be there, should be taken into consideration. When the perifacial lymph nodes are more and the tissue edema, if we are doing the salvage neck after chemoradiation, then there may be a difficulty in identifying the marginal mandibular nerve. But as soon as possible as we should preserve it and remove all the lymph nodes around the facial artery and facial vein and marginal mandibular nerve.
So, so we have got a lot of postgraduates joining in. So your recommendation will be to, as a beginner, to try to identify the marginal mandibular nerve, dissect it, and once you kind of identify to understand, to pick up the perifacial node, then you can try avoiding dissecting the nerve, because that always
best
has
is to try to avoid the monopolar cautery in that area, because when you dissect the perifacial nodes, there is small ooze starts. In that ooze, don't try to use the monopolar Khatri. Try to press it and use bipolar Khatri.
And Madam brought out a very important point that it's very important once you dissect the nerve to dissect the nerve all throughout the course, right? So otherwise what happens, we try to dissect it anteriorly, but when we go posteriorly, we may end up cutting it. So that's a very important point which Madam brought out, and that has to be taken into account when we are dissecting.
We have to identify till the parotid gland posteriorly.
Right. I think Madam joined in, so we'll...
Yeah, Madam is there. Gauri ma'am. Gauri ma'am, ma'am's mic is silent. Can you tell ma'am? Ma'am? Ma'am is there, I think.
All right.
Gauri ma'am? Ma'am, can you hear us? Gauri ma'am? Ma'am, can you hear us? I don't think. Akshay?
Right, okay. So if there is a perifacial node, you dissect it in entirety and preserve it. But if it's an N0 neck, probably once you have got some experience, probably you can kind of not dissect the nerve too much. But as a beginner, it's very important to identify the nerve and dissect it all throughout, right?
Ma'am, can you hear us? Gauri ma'am? Gauri ma'am, can you hear us?
Probably she
is messaging. Okay. Okay, next question, Akshay. How in post chemoradiotherapy or post radiotherapy salvage neck dissection, how to take care of the skin flaps, how to do neck, what are the tips for doing the salvage neck dissection? Can you help, Akshay?
Yeah, so Madam has just mentioned, so you can type questions.
Hello?
Yeah, so, ma'am, can you hear us?
Hello?
Gauri ma'am? Yeah, can you hear us, ma'am? Ma'am, can you hear us?
Sorry, I can't hear your type.
Your connection is poor.
For some
Akshay,
reason,
you can
I'm
answer.
just unable to hear you. Can you hear me?
I think you can.
I can hear you. I can hear you, ma'am. Akshay?
Yeah.
Dr. Akshay?
Yeah.
Yeah.
Let me try somewhere else. Hold on.
Akshay, in between, you tell us about what are the incisions you will like to do in post-RT cases.
So with regards to post-op, when you're dealing with a post-RT or a salvage...
Yeah, I can hear you, ma'am. Dr. Gauri? Akshay, you start.
So yeah.
Hello?
Ma'am? Yeah, I can hear you, ma'am.
Can you hear me?
I can hear you, ma'am.
I cannot hear you all, but...
How it is possible? Okay, Akshay, you go ahead with the salvage.
Right. So in terms of when you're dealing with the salvage neck dissection, the things to take into account is that when you're planning the skin incisions, it is better to avoid three-point junctions.
Very important.
Number two is that it is better to use cold steel instruments, that is knife or a scissors, to cut or dissect the tissue, and avoid monopolar cautery as much as possible. Try to raise, as mentioned, as Madam mentioned, as thick flap as possible. Raise the flap, a nice subplatysmal flap.
But we have to keep the fibrofatty and lymphatic tissue in the neck, I think.
Yeah. So thick flap, subplatysmal, avoid three-point junction, avoid cautery as much as possible.
Right. Very good. And what about the vessel management? How to do? Should we use the vessel diathermies near the post-RT cases, more or less that thing for the PGs?
So the basic is to avoid monopolar cautery forceps and to try to dissect using more of a blunt instruments. Use artery forceps. Try to dissect, get into the right planes. Study the preoperative radiology well. So studying the radiology well is important to have a proper plan preoperatively. So what is the extent of involvement of neural tissue, if at all it is attached to the vascular structures, what is the relation to the prevertebral.
Hello?
Yeah, ma'am, I can hear you. Can you hear me? Hello? Gauri, ma'am? Akshay, please continue, Akshay. Dr. Akshay?
Yeah, so I think
Yeah, please continue.
So basically, when we are dealing in a salvage situation, we need to take into account the radiology very well. So we need to make a decision about operability prior and to avoid the complications. So in those situations, what we are encountering is mainly, as Madam rightly beautifully described the complication very well. So she divided into nerve injuries, the vascular
injury.
nerve injuries, vascular injuries, and the wound-related complications, and the very pertinent bile-related issues which we encounter on the left side, and very appropriately on the thyroid with multiple lymph nodes, right?
Yeah.
So the planning is important.
Akshay, have you done any McPhee type of incision in salvage cases? Do we do presently or no?
So,
for the PGs?
So for a McPhee is generally preferred when you're doing a salvage neck dissection, especially in patients who have got a long neck. Neck, and we have to clear level 1 to 5. In that situation, it is difficult to address all the groups of lymph nodes with just a transverse cervical neck crease incision. And it is not advisable to do a 3-pointer or a modified Schaubinger kind of an incision. In that situation, you do a McPhee incision. But what is important in planning a McPhee incision is that the distance between the two neck incision should be at least about 3 to 4 centimeters. Otherwise, there may be wound issues.
Right. Agree 100%. Next question is is there role of external carotid artery ligation? Does it have any role? I think personally, when the level 2 lymph node is there, large lymph node encasing the carotid, then when it is going to near the hypoglossal nerve, then we have to sometimes ligate the external carotid artery, because it will give us the good exposure, and the rest of the internal we can save very nicely. Akshay, it's your call now.
Should I answer this question for
Sure, ma'am. Now I can hear you. Kindly, no, ma'am. One more question is there. Does ligation of external carotid artery has any role during the neck dissection in big nodes? Gauri, ma'am. Hello. Akshay, please you go ahead. Madam cannot hear us. Dr. Akshay.
Yeah, regarding external carotid artery ligation, is it?
Yeah.
So see,
I can answer this question on neck dissection and tracheostomy. Can you all hear me?
Yeah, ma'am.
If you all can just say yes in the chat box.
Yes, ma'am. Please go ahead.
Okay. So somebody's telling me not to interrupt Akshay. I'll let Akshay speak if.
No, ma'am. Please, you go ahead now, please.
Okay, so let's talk about one is octreotide for chyle leak preservation. It seems like a very interesting option because you feel that you'll give octreotide and it stops. So I have used octreotide in around 5 to 10 patients, and high volume fistulas do become lesser. It doesn't really work too well in low volume fistulas. It may therefore prevent the need to do surgical re-exploration. So if your initial conservative management is not decreasing the volume of your fistula, you may try octreotide therapy, but it does not have very reliable results. So it's a lot of expense and you're not sure if it will work, but to decrease a high volume to a low volume fistula, you may be able to use it. The second one is on the neck dissection and tracheostomy, how to make sure the drains hold. What we do is we try to avoid going towards the area So your neck dissection should not cross your straps. That's your medial boundary. So first avoid crossing your straps and you won't open that fascia there. But if you do open that fascia there, we do take a few stitches around the tracheostomy from inside the neck dissection to try to make the drains hold for these patients. Now there are two questions. One is it advisable to retract the spinal accessory nerve with a vein loop eyelid while dissection of level 2B? The question here is that ideally nothing is advisable, but it's better than using your cautery on the spinal accessory. So it all depends on where your spinal accessory is anatomically. If it is a very lateral spinal accessory, then you need to pull it, and probably you can use a vein loop, but the person who's pulling the vein loop, and it's often your first assistant, and they are generally bored and they want to do the surgery, so they pull it really hard because they've gone off to sleep. Now that cannot happen. So you have to see that that pull is very, very gentle. In a salvage neck dissection post-RT, what is the best way to differentiate nodes adhered to vessels due to fibrosis versus invasion to inadvertently damage the vessel? Now, this is a combination of your radiology and your intraoperative findings. So you're going to be, if you're doing a large case which radiologically seems like it's involving the carotid artery, then there is a higher chance that this is what you will find intraoperatively. But otherwise, sometimes you have very small nodes, but they're really stuck to the carotid artery, and you have not anticipated that it would be involving. And the way to find out involvement is to really, the only way to do it is to go really close to your carotid artery, far away from where your node is. So if you find that you're not able to get the plane, first you leave that area. Don't keep dissecting in that same area, because if you have a weakened wall there, you'll injure it. Go to a native area, a dissection naive area, open the carotid sheath, and you can go very close to the carotid artery. And really, in very, very rare circumstances, it's actually involved. You, of course, have to think of whether before you do all these complicated dissections, if you find that it's involving the carotid artery, first see that this is a good prognosis patient. This is not a patient who also has a lot of lymph nodes at level 4, level 5 before you go ahead and do it. So the way to do it is to go to a treatment naive area, go really close to the carotid artery with a vascular forceps and a fine mosquito, dissect from there and go towards the area which has the node probably stuck. I have a question of there's a question called injury to the sympathetic chain. And this is really, injury to sympathetic chain does occur. It's a very difficult structure to actually identify. And if you maintain the regular good technique while doing regular neck dissections, you don't injure the sympathetic chain. It only happens when you have really large M3 nodes and you're involved and you've gone behind the vagus, and that's where you hit the sympathetic chain. And you just have to be conscious of the presence of the sympathetic chain. It's an extremely difficult structure to identify. Management of accidental injury of carotid artery and its management, as I think I covered this on how we should manage the carotid artery. I have a question on when we are dissecting level 5, you mentioned that the SA is left in the bed. Can you elaborate on this? So what I meant was that if you're doing a level 5 dissection as a completion of a modified neck dissection because you have positive nodes, and there aren't really major level 5 nodes, then you don't need to elevate the entire spinal accessory nerve off its bed. You can operate below it, which is the 5B, and above it, which is the 5A, without dissecting posterior to the spinal accessory nerve. Please enlighten me about your level 2B and level 5 metastasis experience. Sumit, we don't generally do level 2B and level 5 metastasis unless we have one positive node in that area, or you find level 2A positive.
Ma'am, again, please, loud. I cannot hear you, ma'am. Hello, Gauri, ma'am. Gauri ma'am?
Structures encased. Most of the times, other than the carotid artery, if this is a good prognosis, and I think this is something that you have, this is a decision not just on your clinical ability and your ability to operate. When vital structures in a post-RT situation are involved, I think you need to go back and think whether resection surgery in this patient is really important. Now, if you have opened the neck and then you find out that these are involved, you again can back off. If you're going to be cutting off someone's vagus nerve and giving them aspiration, or you're going to be injuring the carotid artery, really it doesn't make sense for things like squamous carcinoma, which has relapsed post-radiotherapy. So I think it's not just your surgical technique, but also you have to understand what is the prognosis of the patient you're dealing with. Is there any method to avoid accidental injury to carotid bulb being mistaken for a node? So the thing that I tell all my residents is you have to dissect in that area. As soon as you find the internal jugular vein, you need to dissect on the lateral, and you saw it in my video also. I will always dissect the lateral border of the vein, and then I will keep my finger at the lateral border of the vein and palpate for any pulsations. If I find any pulsations, generally the carotid artery is more medial and you won't feel pulsations. If you feel pulsations, you should dissect this area with your mosquito rather than just using your diatherapy. Thank you. When to explore or observe a hematoma? Most cases you will explore. As I said, you observe only for very small.
Hello.
Hello.
Hello. Akshay?
Yeah, I think Madam has covered almost all the questions.
Yeah. Very interesting and elaborative talk by the ma'am on this thing. One important last point in Kyle Lake, intraoperatively doing anti-Tendelbach position and giving positive pressure to see the Kyle. That is the important thing, I think. What Akshay is called?
Yeah, okay. Thank you, Sumit. I think all the questions in the chat box have been addressed. Dr. Gauri Madam is telling a bye, and we thank her for a very, very elaborate presentation dealing with the complications. And she had summarized it very well in dividing into the structures which can be involved: neurological, vascular, wound complications, and the very important Kyle Lake. Thank you, Sumit, for moderating the session. It was a very great interacting session. Sorry for the technical glitches we had to encounter in this meeting. Thanks, everyone. Looking forward for participation for the tomorrow's laser meeting and the further Thursday, Saturday's oral cavity modules, which will be following soon. Thanks, Sumit. Thank you, Madam. Madam is not there here, but thank you. Thanks, everyone. Thanks, everyone, for the participation.